Hello, and thank you for allowing me to present to you today. Today, the topic of my presentation is going to be the basics of HIV and sexually transmitted infections for the primary care provider. My name is Terry Hackworth. I am an adult nurse practitioner with a specialty and certification in HIV. I am at Absolute Care Medical Center in pharmacy here in Atlanta. I practice in the Buckhead area, specializing in the care of HIV, PrEP, a main focus of the LGBTQ+ community, as well as gender-affirming hormone therapy. So today, the program objectives will be to review the epidemiology for HIV, sexually transmitted infections, and the need for routine care. We'll describe the basics of transmission of HIV and sexually transmitted infections, along with the increased risk that is associated with each. We'll talk about review and how to conduct a sexual health history. And then we'll also spend a little bit of time on discussing some missed opportunities to prevent HIV and to prevent STIs. And then we'll talk about some prevention methods as well. So first, what is HIV? Well, HIV actually stands for human immunodeficiency virus. HIV attacks the body's immune system, specifically looking at the CD4 cells, or what we also refer to as the T cells. Most commonly, patients are more familiar with the term T cells when they look at their HIV and they want to know about their lab results and how they're doing or how their immune system is responding to their antiretroviral therapy. Currently, there's no effective cure. There's lots of studies that are being conducted as far as vaccine studies and some cure studies. There have been some mixed results, especially where the vaccine study is concerned. And then the other step is right now we have antiretroviral therapy, or ART. You may be very often referred to as ART. Antiretroviral therapy consists of anywhere between 2 to 3 different medications used to suppress and to treat the HIV. In many years past, we often have said that it takes 3 drugs to effectively treat HIV, but with the advances that we've had in HIV medicine over the past few years, what we have seen is that we are able to, with the new drugs that are much more potent, much more effective on the treatment of HIV, we are able now to treat a lot of HIV patients with just 2 drugs. And most often those drugs are in 1 pill, or what we refer to as a single tablet regimen. And so patients are often on 1 pill to manage their HIV daily. And I like to tell my patients the management of HIV is easier for me than managing someone's high blood pressure, managing someone's diabetes. In the reduction, when we talk about reduction of new HIV infections, it's really uneven across the board. We see a lot of this information that's on this slide is actually from 2015 up to around 2014 to 2015. If you look to the left of the slide, it talks about in 2015 up to that point where we were seeing our new infections. There is some new data that recently came out from the CDC. Unfortunately, I have not updated the slide to include that data because it's fairly new. But if we look back to these, the data is not much different in where we are seeing the new infections, who we're seeing new infections in. 67% of infections are often seen in men who have sex with men, or MSM. You may see that abbreviation. You look at, we had approximately 40,000 new infections in 2015. Most often the age range on the right of the slide, you can see the age ranges of where we see a lot of our new infections, and that age range is in the age group of 25 to 34 is where we see most of our new infections. And that really hasn't changed from 2015. We are still seeing a large portion of those new infections affect our younger generation, specifically men who have sex with men, people who inject drugs, and then also MSM who inject drugs. So it's pretty uneven. We did see a 10% decline going up from 2010 to 2015. But overall, the group of MSM or men who have sex with men overall did not experience a decline, and that holds true still today. You will see higher prevalence in certain populations throughout the United States. If you look toward the top of the slide, you'll see how some areas in the United States actually are compared to some other countries. For example, Washington, D.C. If you look at Washington, D.C., the overall prevalence is 1.9. But when you break it down and look at Washington, D.C. Blacks versus Washington, D.C. Black men, you'll actually see a significant increase of 4.4 in Black men. We typically also see the same type of increase if you look at New Orleans, you look at New York City. Down at the bottom, in comparison, you can see how that compares to some of the other countries, such as Thailand. I mean, New York City, and the rate in New York City is higher than that of Thailand. When you look at lifetime risk associated with HIV diagnosis based on race and ethnicity, when you're looking at lifetime risk of HIV diagnosis on the left, we see that among African-American men, it's 1 in 20. In African-American women, it's 1 in 48. Hispanic men is also 1 in 48. In Hispanic women, it's 1 in 227. And I apologize that that is not highlighted on the slide and written the way that that you can read it, but those columns, bar graphs are referring to women. In white men, it's 1 to 132. And in white women, 1 in 880. Conversely, when you look at the HIV risk of HIV diagnosis among men who have sex with men by race and ethnicity, we see a dramatic change. Total MSN is 1 in 6. But if you look at African-American men who have sex with men, it goes to 1 in 2. So there's a 1 in 2 chance that an African-American man who has sex with other men has a 1 in 2 chance of acquiring HIV over their lifetime. Hispanic men is 1 in 4, and white MSM is 1 in 11. This is a little bit busy of a slide. I'm not going to go over everything specifically on a slide. But if you look at approximately, and even though there's been more effort and more interventions put in to trying to decrease the prevalence of HIV, there's approximately about 40 to 50,000 people who are diagnosed each year with HIV. And then there are other populations that are very disproportionately affected, especially if you look at Black African-American men, or the race in general, the rate is much higher. Over to the left, you see by age. Again, the orange line is those that are 25 to 34, which is where we see a much higher increase going up to through 2017. In the middle is by race and ethnicity. If you look at the orange line again, it has decreased since 2007, but we still see a much higher prevalence in Blacks. And then by gender, we do see a much higher rate of incidence by males than we do in females. So approximately 15% of people living with HIV, or 1 in 7, do not know their HIV status. Thus, that is increasing the risk for transmission of the virus. If you don't know you're infected, you don't get tested, you don't believe you have a reason to be tested, then your HIV viral load is going to be much higher. It's going to be much more of a possibility that having unprotected or condomless sex with another individual is going to lead to transmission of the virus. When we look at transgender men and women and the prevalence of HIV within that, I think it's important that we also look at this specific patient population, because we see by that first point I have on the slide, about 1.4 million Americans do identify as transgender. Over 1/2 of those patients that are diagnosed with HIV are Black or African American, and approximately 89% of transgender people believe that it is important that healthcare, those of us that are healthcare providers, that we know their gender identity and how they identify. Transgender women, the prevalence is about 522 per 100,000. They are 49 times more likely to be living with HIV compared to the general population. Approximately 22% of women in the US are HIV positive. Transgender women are HIV positive. And 72% of transgender women do perceive themselves to be at low or no HIV risk. That's an important point to take home, is because if you don't perceive yourself to be at risk or perceive yourself to be at low risk, the lack of ability or the lack of willingness to be tested or to go to have a test or to be assessed for HIV is much lower, and they're not likely to have that testing done. So therefore, that increases the risk that they may transmit the HIV to their partners. When we look at transgender men, the prevalence is lower. It's 256 per 100,000. There's not a whole lot of data, especially in the transgender population in general, but specifically to transgender men. There's about 15.4% of new HIV diagnoses in transgender people were transgender people that were recognized to be transgender men. And 69% of them do report condomless sex with a cisgender male. So again, perception of risk is really important. Perception of how we get our patients to understand that they are at risk. And by engaging in condomless sex, how much significantly higher that elevates the risk. STIs have reached a all-time high in the US, and we can often look at those that are presenting a major public health crisis in the United States. In 2017, in the United States, approximately 2.3 million cases of chlamydia, gonorrhea, and syphilis were reported. And that went up by 200 cases from what was seen for 2016. I did obtain some new data, the most recent data that CDC had available on their website. And although the increases in the past few years have been much more significant, or we did see more milder increases, when you look at chlamydia, cases went up 2.8% from 2018 to 2019. There were approximately 3,728 per 100,000 reported cases. Those were between the ages of 15 to 24. So that was about 61% of all reported cases in the year. So it highlights a little bit of the educational aspect that needs to be done for our younger generation, looking at those that are in pre or in middle adolescence to late adolescence to early adulthood. In the middle, gonorrhea cases went up 5.7% when compared 2019 to 2020. We also seen back in the 7 years between 2010 and 2017 that it increased among men who have sex with men by 26.5%. There was some new data that I had found on the CDC related specifically to MSM, but we did see a 5.7% increase in gonorrhea. Syphilis has the highest increase. This typically happens pretty much every year that we get data from. So if you're looking at 2019 to 2020, there was a 6.8% increase in syphilis affecting men of sex with men and women of childbearing age. It's important that women of childbearing age be screened for syphilis. There can be prenatal and transmission during birth to the infant, and so therefore it's important that these patients be screened for syphilis. There's a definite relationship between STIs and HIV risk, and let me just see. Okay, here we go. 25% of individuals newly diagnosed with HIV also had a sexually transmitted infection within 6 months prior to their diagnosis. So there is definitely an association when you look at patients who have a high prevalence or often see you for the treatment or for the diagnosis or for symptoms related to STI, sexually transmitted infections, that they should be being screened for HIV as well. STIs can facilitate the transmission of HIV because of the mucosal environment. So when the mucosal environment is compromised with chlamydia, gonorrhea, there's an increased risk and an increased the ability for HIV to transmit to the unaffected person. Epidemiology and social determinants, sexual networks, geography, dating apps for the facilitation of casual sex. Dating apps significantly can increase someone's risk of HIV. Partners are much more readily available. Sexual encounters can be much more regularly facilitated. found when patients are using these quote-unquote dating apps. There's lots of those to be familiar with. I will talk about that a little bit down the road in the presentation. We'll touch on that briefly when we're talking about sexual health history and some of those aspects here. But it's important to note that STIs and HIV have a direct correlation. So if you're working in primary care and a patient is coming to see you, they're concerned about a sexually transmitted infection that tells you that they're sexually active, that tells you that they've engaged in maybe some sexual behavior that may have put them at risk or placed them at risk. And so therefore it's important to ascertain their last HIV test, order an HIV test, regardless of sex, sexual gender, regardless of birth gender, regardless of how they were assigned at birth or how they identify. Those patients need to be screened for HIV in addition to the STI that they're coming to see you for or the symptoms that they're coming to see you for. The correlation of HIV risk associated with STIs can be considered to be complex. STIs that cause ulcers and inflammation will greatly increase the risk of transmission of HIV. There can be as much as a 5 times increased risk when you look at genital ulcers, such as herpes or HSV. Within the vaginal microbiome, they're associated with greater risk for HIV acquisition in women. So because of those ulcers there, the way that it alters the vaginal mucosa will actually increase the risk. There's a 10% of incident HIV infections seen in men who have sex with men caused by the prevalence of gonorrhea and chlamydia. So in the big box, it tells you there's a known direct correlation between the incidence of rectal gonorrhea infections and the increased incidence of HIV infection in men who have sex with men. So again, that anal mucosa, there is an infection already there. The mucosa is already compromised. You introduce a new virion or a new virus into that environment, is going to be much more readily easy to be transmitted to that sexual partner when you already have those things in place. So anytime anyone is complaining of symptoms that are consistent with an STI, that they may have been exposed to an STI, an HIV test should also be on your radar, and it should be also on that STI panel if it is already not there. Additional STIs that signal the need to talk about more detailed sexual health history and to assess for the risk of HIV are any of those you see here. HPV, it is the most common STI in the United States. There's about 80 million or 1 in 4 people who are currently infected. I like to tell my patients to help them understand how prevalent HPV is that basically anyone who's had sex has probably been exposed or has an increased risk of being exposed. Sexually acquired hepatitis B infections, we do see about 2.2 million people per year. Back in 2016, there was about 21,000 new cases every year. I didn't find any additional data on that yet either. However, I'm sure that we would see approximately roughly about that. Genital herpes, again, much more prevalent ages 14 to 49. There was an increased prevalence in both HSV1 and HSV2. And hepatitis 3 or hepatitis C. Hepatitis C chronically infects about 3.5 million people per year. Total are living with chronic HCV, about 40,000 cases per year. I do also treat hepatitis C in my practice. I do see it fairly common. I see it a lot of in new HIV infections. We'll find them to be co-infected with hepatitis C or co-infected with hepatitis B. Again, that's a word to look for. If you also, when you're doing your STI panels, if you don't know your patient's hepatitis B, hepatitis A, hepatitis C status, if they fall into a high risk category for those when you're taking a sexual health history, then it will be very important to add those on your sexual health history or add those onto your laboratory so that you can screen them for hepatitis C and screen them for hep B, as well as screen their immunity to hep A and hep B. We do have vaccines available for both of those, so it's important if you screen them for those, they're not found to be immune, they don't have an active infection, then they should be vaccinated for hepatitis A and hepatitis B. Behaviors increasing risk of STI and HIV, having vaginal, anal, or oral sex without a condom, Without a condom with someone living with HIV who's not virologically suppressed. And by virologically suppressed, we're talking about a patient who consistently takes their ARVs, their antiretroviral therapy, consistently sees their healthcare provider and knows that their HIV is well controlled, that it is below the level of detectability, which is 20 copies in the lab. So we consider anything to be less than 20 copies to be undetectable. So that patient is virologically suppressed. You have an increased risk of STI and HIV with partners of an unknown STI or HIV status. So it's important to know the status of your partners. For people who have sex in exchange for commodities, whether that's be for rent, housing, food, shelter, those type of commodities, when they're engaged in high-risk behaviors as exchanging for commodities, are much more higher risk for STIs than for HIV. And then while under the influence of drugs or alcohol, those inhibitions are lower. People tend to take greater risk, engage in more riskier behavior, such as condomless sex. That can increase the risk of STI and HIV, of course. And then the consistently and correctly, let me underline correctly, using latex or polyurethane condoms with lubricant. Lubricant helps reduce the friction, which will decrease the risk of a condom breaking, tearing. This will lower one's chances of acquiring HIV and certain other STIs, whether the sex be anal or vaginal. We also tell patients that the choice of lubricant, there are a couple of different lubricants out there that actually, in some studies in the past, were shown to increase transmission of HIV. Those are readily available on the market any longer. Other than I do believe there is one that the name is escaping me right now that is not often used for sexual intercourse, but should not be. Get the name of that. When looking at drugs and alcohol, there is a higher prevalence. Those patients you should also be looking at doing when you're doing your history, talking to them about their drug. Do they have a substance past? Do they have any substance issues? Do they consistently use alcohol when they're dating or when they're out on the weekends and with their friends and such? And just making note that they may increase their risk. Some other factors that can increase risk for acquiring STIs, including HIV. If we look to the left, we're talking about some social and sexual networks. When we talk about social and sexual networks, that is the risk basically depends on location of their partners in their sexual network, the prevalence of STIs that are in that network. So when we're talking about network, we're talking about a group. There are in your social context. Basically, some patients will say, well, I have one or two consistent partners, and that's the only two people that I have sex with. Okay, well, if that's the only two people you have sex with, then who are the people they're having sex with? Are you the only person that person is having sex with? Because if you have sex with two people, that person's having sex with two other people, then your risk is increased because you've now been exposed to all those two people. Those two, they have two each. So you have 2, 4, 6, you're up to roughly being exposed to 6 other different partners. If they have maybe acquired something from a partner they don't know, and then they have sex with you, then that can increase that risk of STIs or HIV just through your social and sexual networks. Location. If a person lives in a geographical area that has a high prevalence of a certain STI, then there will likely be an increased risk the person acquiring that STI. For example, syphilis is much higher and prevalent here in the Atlanta area in comparison to gonorrhea and chlamydia. I believe the last study or the last number shown that it was syphilis, gonorrhea, followed by chlamydia. So those here in Atlanta, especially within the gay community, the men who have sex with men, in our HIV community, we see a much more higher prevalence of syphilis. And so that's something to know. It's something for the community to know, for your patients to know that they live in a geographical area that may increase their risk of acquiring syphilis. Finding sexual partners via venues or platforms that facilitate casual sex. And then this, we're talking about things like in the past, bed houses. There is one here in Atlanta that were dating apps. it's important that in your sexual health history, and we'll talk about it in a little bit, of talking to your patients about how they meet their partners. Do they meet their partners in bars? Do they meet their partners online? Do they meet them through a dating app such as Grindr, Scruff? Those are some of the more common ones within the gay community. Tinder, which crosses both demographics. This can also increase the risk of STIs. And then on the far right, we look at social and structural barriers to engagement of care. So patients who don't engage in care with their healthcare provider or don't provide that information to their healthcare provider can increase the risk. So basically, maybe it's associated with stigma within their community. There may be some stigma associated with going to the doctor, talking about your sexual life, talking about how you meet or what you do with your partner. The social inequities, such as, along with poverty, sexual violence, incarceration, lack of education on STIs and HIV and the transmission thereof. I'm often not ever really surprised, but I'm often run into people who are still uneducated, especially the younger generation. We're talking early 20s, which may be why we've seen increased incidence among the age group, that don't understand the basics of transmission of certain STIs or the transmission of HIV because they never been provided with that education. And with the way some things have been going within our modern education system and what teachers can talk about, what they can't talk about, and what some of the education that our young people are not getting nowadays can actually, I'm concerned about what will go with that for the future when it comes to their risk. If, parents are going to need to take a role in discussing sexual education with their children and with their young adults in order to help decrease their risk of being exposed. We do see, I have seen HIV exposures from late teens to the 60s. If they're in an environment that has little or no access to healthcare, or a limited choice of healthcare providers. I think limited choice of healthcare providers is something to look at because not everyone feels comfortable coming out with either their sexual identity, their gender identity, how they meet their partners. When it comes to certain healthcare providers for fear of that stigma or fear of not being accepted by their healthcare provider or getting the appropriate care. So if they have a limited choice of healthcare providers, that can increase their risk, or finding a provider that is versed in care that aligns with their sexual or their gender identity. The next section talks about conducting a sexual health history and the importance of a non-judgmental approach. This is one of my own little pet peeves because I do sexual health histories every day. And I think that it's something that's sorely missed in primary care. I think a lot of patients or providers sometimes have to not be comfortable with talking to their patients about sex and sexual health. Leads to us not taking an appropriate sexual health history, not knowing when our patients are at risk for an STI or for HIV. So I think that it's very important that in this section that we all be very comfortable with performing a sexual health history. When we look back at some data that was collected back in 2016, as far as patients are, I think this is 2012 to 2014, it was published in 2016, their own perception of HIV risk. So when a patient looks at their risk, self-perception of risk, when you look at male and female, 50% of males, 7% of males had a self-perception of risk, whereas only 8% of females had a self-perception of risk. But when you look at the tester's evaluation of their risk, males, it went up to 72%, and for females, it went up to 60%. So you can tell that a large amount of these patients that are at a moderate to high level of risk of acquiring HIV, especially in the women, don't perceive themselves at risk. So question is to think to yourself is, why is that? Why do, especially women, not see themselves at higher risk? I think part of the self-perception issue is that a lot of them don't see themselves at risk because they believe themselves that they're in a monogamous relationship with their partner, and that partner does not have any other partners. I think that's one aspect of it that has to be looked at. And then I think that it's just my experience has been that it's been much more acceptable or much more seen by women that they don't consider themselves at risk because they themselves are not engaging in any risky behavior. They're looking at themselves not so much as taking into consideration what the partner may be engaging in or may not even know what their partner is engaging in. That can hold true for men as well. That's why there's a little bit difference in that number if you look at that. But I think that women are much more or less likely to ask a lot of the questions is what I've seen in my own personal practice. Stigma can create a real barrier to having an appropriate sexual health dialogue. HIV stigma can be associated with misunderstandings about the disease or the behaviors that are considered to be quote unquote deviant from the societal norms, such as drug use or sex work. People may also reject someone as HIV positive because they're scared. There's a fear there that they're going to get HIV themselves. And one thing for you to think about, have you ever hesitated to perform a sexual health history on a patient of yours? And if you have, I want you to think about why. The little screenshot that you see down at the bottom of it comes from an app called Grindr. Grindr is one of the social apps and dating apps and apps used by gay men to facilitate sexual encounters. And the one in the blue is the person who's contacted someone saying you don't have an HIV status on your profile. The person says your point is. The other one says as a safety precaution, I refuse to play anyone who has HIV. They're a danger to themselves. That's an example of stigma. It's an example of that person not being educated. When someone who's HIV positive is biologically suppressed, who is on their ARVs and taking their medication daily as they're supposed to, is what we refer to as undetectable. And when a patient is undetectable, the virus is untransmittable. So whether those two partners agree to use a condom or use some type of barrier or to engage in condom sex, the risk for the HIV negative partner is not there. It's that person who is undetectable is not going to transmit that virus. So I think there's a lot of education left to be done in that aspect of it. And I think a lot of times that's what leads to a huge amount of stigma is just misinformation and people not being educated about how the disease actually works. We often see in the gay community, we often see terms used as clean or dirty or clean, quote unquote, are you clean and drug and disease free? We're all clean. We all take showers. Most of us take a shower. So therefore we are clean. So that is a very derogatory term to use towards someone who may be HIV positive or who is HIV positive. Performing a sexual health history. It's extremely and recommended for all adult and adolescent patients, and it should be a part of your ongoing primary care. Some barriers that we see to someone taking a sexual health history, maybe they came in for an urgent type care issue. Maybe they came in for for something that's not related to a STI or not related to a reason why you might see the opportunity to use a sexual or to do a sexual health history. We as providers, we may be uncomfortable. You may not be uncomfortable or think that the questions you're going to ask is make your patient uncomfortable. Most of the time, patients will share what they want to share, but if they sense that you're not comfortable, you're nervous, you're afraid to ask the questions or have a fear of answering those questions or asking those questions, and patients too are going to have an issue with that. They're not going to answer the questions. They're not going to provide you with the information that you may need or want. They may not be too comfortable talking about their sexual health history or their partners or their practices. But a lot of times it has to do with our approach. It has to do with how we approach that topic, how we talk to the patient about their sexual health history, and that we're being non-judgmental when we're assessing for that, asking and assessing that information. Some benefits to the sexual health history, there's much more benefit than there's barriers should be. It gives you an opportunity to build your trust with your patient. If your patient can trust you, they know that you are non-judgmental, that you're not going to judge them from the things that they tell you, then they're much more going to share a lot more information with you to where you can appropriately assess the risk. It gives you an opportunity to talk about risk reduction counseling, and talk about, if you're familiar with PrEP, what barrier methods do they use? How do they have sex? Who do they have sex with? How can you help them understand how to reduce their risk? Looking at birth control needs. Do they need to be on birth control? Are they on birth control? Again, what barrier methods are they using? Opportunity for support consistent and correct condom use. Let me underline correct again. You would be surprised how many people don't always use a condom appropriately or correctly and appropriately. Identification of being, you will then be able to identify your patients who are at risk for STIs, including HIV. Talk about appropriate prevention methods and also appropriate anatomical sites collection. I often talk about 3-site collection. When we talk about 3-site collection, we're talking about doing site collection for a gay male or for a male, gay male. We're looking at a urine for gonorrhea and chlamydia. Oftentimes I'll see patients come to me for PrEP who've been referred either by their primary care provider or referred by another provider. And when I talk to them doing their sexual health history and how they've been screened for STIs in the past, they will often tell me, well, they took a urine. And that's where it stops. And I will look at them and say, okay, so you've not had your throat swabbed for any STIs such as gonorrhea and chlamydia. And they will tell me no. And I'm like, well, do you engage in oral sex? Or providing oral sex to your partner? And they will say yes. And so therefore they're at risk for gonorrhea and chlamydia in your throat and they should be swabbed. If they participate in anal receptive intercourse, the anal canal should be swabbed. So that is your 3-site collections: GC, urine, throat, and rectal. When you talk to your female patients, again, 3-site collection. Are we looking at, do they need a throat swab if they're engaging in oral sex? They're providing oral sex to their partner. They need a vaginal swab for gonorrhea and chlamydia, and they also need to be assessed for any rectal intercourse. There are, females do have anal receptive intercourse, and I think a lot of times that is often missed and often not asked of our female patients when we're talking to them. We just make assumptions that we may be not providing them the most accurate information or be able to assess their appropriate risk if we're not asking all the right questions. Some steps to performing a sexual health history. 1, you need to establish trust and rapport with your patient. You need to put them at ease and let them know that this is what we're going to talk about. It's an important part of their history. It's an important part of you being able to take better care of them. And that you do talk to all your patients and you ask these questions of all your patients, not just the ones that you have a perception that may be of an increased risk, but that these should be done on all of our patients, regardless of age, regardless of, if they're sexually active, we should be doing a sexual health history. Then we have the 5 P's of sexual health: partners, practices, past history, prevention, and pregnancy plans. So those are our 5 P's of sexual health. When we talk about partners, we want to ask them about the number and gender of their partners. The way that I like to open up my discussions with my patients, especially if it's a new patient of mine, is to look at them and say, okay, we're going to perform your sexual health history now. I do this with all of my patients, and it helps provide me a guide on how to better take care of you and to better assess your risk as we go down the road. So the first thing I'd like to know is, do you have sex with men, women, or both? That's a very non-judgmental way of asking them who their sexual partners are and gives you a very good idea of where to assess the risk. Look at their partner's risk factors and their personal risk factors. Look at their, talk to them about their past sexual partners, any past histories. We'll talk about that in a second. Do they or their partner engage in any substance use? Again, remember back to when I was talking earlier about substance use, drugs and alcohol increases the susceptibility to STIs and HIV. If you have multiple partners in the last 12 months, explore more specific risk factors, such as what's their condom use? What percentage of the time do they use a condom? What percentage of the time do they not use a condom? When we look at practices, what are their sex practices? How do they have sex? Not just who they have sex with, but what do the sexual activities do they engage in? And the condom use and drug use, how often do they use their condoms? Do they engage in substance use when they have sex? Again, it's very important when you're asking these questions to make the patient feel comfortable and to make sure that you are not presenting anything that may be considered to be judgmental based on what their activities are. Any past history of STIs, sexual practices, condom use, their own perception of their risk, the perception of their partner's risk. When was their last STI or HIV test? What have activity they've had since that time? And then any prior diagnosis. If they're one of your patients who may become pregnant, have they thought about that? What kind of contraceptions do they plan on using? We will talk about prevention. And as we go through this whole thing, we'll touch on prevention the entire time. And this all leads to protection from STIs. Some sample questions for sexual health history. If you look along the bubbles, there's several different bubbles here for you to look at. Tell me about your current sex life. How do you protect yourself from STIs? How many times did you have vaginal or anal sex when you or your partner did not use a condom? These are questions that are non-judgmental. They allow open-ended. They allow your patient to feel comfortable in how they're going to answer this, and it can be going to judge them. Again, non-judgmental communication, that's the most important part. You can talk to them in a sensitive, open, and non-judgmental manner. Use appropriate, open-ended questions. It is not appropriate to look at a patient and say, you always use condoms, right? The term always infers that you're judging them should they say that they don't. So how are they going to answer the question? Oh yeah, sure, I always use condoms. When you know deep down that odds are they do not. Avoid making any assumptions based on the patient's personal factors, including their appearance, their age, their relationship status, sexual orientation, gender, or gender identity. Don't ask them, do you have a husband or boyfriend? If they're cis female, though they identify as cis female, you want you to say, who is your partner? Do you have a consistent sexual partner? You have sex with men, women, or both. Be straightforward, be sensitive and open to different behaviors. Listen to how your patients address themselves and their partners, and then address them as such. If you're unaware of a patient's gender use gender neutral words and language, such as they, them, and theirs. Ask them, what are your pronouns? A lot of times now patients are very comfortable with you just asking them what their pronouns are. Recently in 2021, the CDC did change the STI screening guidelines. I have this chart for you on the board. They recently added the column of transgender and gender diverse. I'm not going to read the entire slide for you. It is available on the CDC website. It's fairly easy to read. It's easy to do. The main takeaways for this is if you look down at the bottom for the bottom column for HIV, when you look at women, men, all men and women between the ages of 13 and 64 should be screened for HIV. So again, all men and women between the ages of 13 and 64 should be screened for HIV. So think about that in your personal patient population and how many patients that actually addresses and how many of those have you tested for HIV recently. General screening for STIs. This talks about that 3-set collection that I was talking about earlier. The proportion of chlamydia and gonorrhea infections that would be missed. This was looking back. It's been a little while. I don't think there's an updated study on this, but in 2008, 2009, we would, if you look at chlamydia, we would have missed 77% of chlamydia infections without extragenital screening and 95% of gonorrhea. And 85% of the time, a rectal gonorrhea or rectal chlamydial infection is going to be asymptomatic. It is rare that I see a patient who exhibits symptoms of rectal gonorrhea or rectal chlamydia. When they do, typically they may complain of itching. They may have complained of a discharge, although that is much more uncommon. Rectal chlamydia can cause an itching. They both can cause a discharge. But because of it being from the rectum, the patient doesn't typically associate that as a discharge. But I do a lot of preps. I do a lot of extrageneral screening. I do a lot of anal swabs, and I find a lot of anal chlamydia and gonorrhea in asymptomatic patients who come in for their routine screens. The CDC did also recently update recommended treatment guidelines for STIs. The one that I really want to point out to you, because we're all very versed in using the azithromycin 1 gram dose for chlamydial infections, but it is not first-line treatment anymore as of 2021. Chlamydial infections in adults and adolescents, the first line is now doxycycline, 100 milligrams orally, twice daily for 7 days. If not available, then you can use azithromycin 1 gram in a single dose, or you can also use levofloxacin 500 milligrams once a day for 7 days. But ideally, there has been some cases of azithromycin resistant chlamydia, and so the guidelines have been changed. So it is now doxycycline 100 twice a day for 7 days. Gonococcal infections was updated earlier last year or the previous year from the 250 milligrams of ceftriaxone to 500 milligrams of ceftriaxone in a single dose. If they are allergic to cephalosporins, you can use gentamicin in a single dose plus 2 grams of azithromycin orally in a single dose. If you are not able to use ceftriaxone, you can prescribe cefexime 800 milligrams in a single dose. Cefexime can be a little bit hard to get your hands on. I have had times where I have had to use it when a patient's been out of town. They refuse to go to somewhere local like an urgent care or somewhere like that to obtain ceftriaxone, and I have had to call this in. It can be difficult. Some pharmacies do not keep it on the shelf. It's not prescribed real often. So it can be a little bit difficult for them to get their hands on should they need to. For syphilis, primary, secondary, and early latent, that is less than 1 year, it is still the benzopenicillin G, 2.4 million units in a single dose. If it is latent or greater than 1 year, or you don't know the duration, that is 2.4 million units. The item in 3 doses at 1 week intervals to a total of 7.2 million units. All right, let's talk about some missed opportunities and methods for prevention as we're getting down to the last several slides. Testing for STI provides opportunity to prevent HIV. So most STIs, again, are asymptomatic at all sites. So we need to test all sites. So we're talking about your urethra, the pharynx, and the rectum, regardless of condom use. Venous sex men should be tested at least every 3 to 6 months, so the very most 6 months, because we know that STIs can facilitate HIV transmission. Sexually active women over 25 years of age should be screened annually for chlamydia and gonorrhea, although I would probably screen them much more sooner than that. In RPR blood tests for syphilis, self-collected swabs are acceptable. So I do have several patients who like to self-collect their rectal swab. They don't want me to do that for them. Most of my patients prefer that I do it because they do want it to, they feel like if I do it, it will be done correctly, and they'll feel much more at ease with the results. And then you also need to be sure that you're informing your patients on which STIs are reportable to the health department and what steps to take for partner notification. Some cues that represent opportunities for you to take a sexual history on your patient. Some of these cues indicate their increased likelihood to engage in condomless sex. If they come in with an STI diagnosis where they request a test, they request an HIV, if they recently were on post-exposure prophylaxis, if they're coming to talk to you about PrEP, and hopefully I hope you see patients who actually come to talk to you about PrEP. They talk about having multiple partners or they're in non-monogamous relationships. Again, the high prevalence area or networks. They're using dating apps. This is where, when you're doing your health history, we talk about where do you find your partners? How do you find your partners? Circumstantial, if they're engaging sex for commodities, food, money, food, shelter, drugs, recreational drug abuse, if they're in a domestic violence or sexual assault situation, if they're incarcerated. There's a lot, that's a whole other topic we can spend a whole other hour on, is talking about incarceration and HIV and STIs. If they're asking about hormonal birth control, either emergency contraception or pregnancy. And don't forget, your provider bias and stigma can be a barrier to HIV discussions with your patient. That's why it's important for us to check ourselves, know where we are. Methods of prevention, sex education, prevention education. Educate your patients about as much as you can about the updated information which STIs and HIV is concerned. Talk about different type of safer sexual options. I'm fortunate to have a peer counselor in my office who works with our patients. Our patients I see who are having regular occurrences of STIs. I can bring her in as a peer counselor. She can sit down with them, talk to them about their behaviors, talk to them about what they have going on. Take a sexual health history at your initial visit, during your routine preventative exams, first signs of STIs. Take every opportunity to do a sexual health history when you can. And then look at when you need to be doing STI screenings and HIV screens, how often you need to be doing those, every 3 to 6 months, depending on the risk factors. In our arsenal, as a prevention method, we do have pre-exposure prophylaxis or PrEP. We do now have, I have another slide in here I'll show you in a second as far as DESCOVY goes. We have Truvada, DESCOVY, and more recently this past January, the FDA approved a drug called Hackworth, which is our first injectable PrEP. Truvada and DESCOVY, they're all used to decrease the risk of HIV. They're all approved in for different populations. Aptitude is approved across the board for cis men, cis women, transgender men, transgender women. And DESCOVY, I'll talk about in a second what the differences is with DESCOVY, but Truvada is available to be used for those, and it is generic now. For those who are at risk of acquiring HIV in adult and adolescents who are over 35 kilograms and at risk for HIV. This can be used in the cis males, cis females, transgender men and transgender women, as well as one pill once a day. This could be another whole presentation on how to prescribe PrEP, and I do that as well. You have those type of presentations available. Exposure prophylaxis contraindications is contraindicated if you don't know the patient's HIV status. Like I was saying, it's 1 tablet once a day. They should be tested for HIV prior to initiating and at least every 3 months. And their guidelines recently updated. That is with at least twice a year, they need to have an HIV PCR viral load test. And every visit, they should have a rapid HIV test. You should screen for hepatitis B prior to infection and when initiating the treatment. And renal impairment is not recommended for individuals who have a creatinine clearance of less than 60. So Truvada would not, if they have creatinine clearance less than 60, Truvada would not be the method of PrEP that you would use for that particular patient. It's also part of a comprehensive risk reduction strategy. So it's only part of your strategy. It's not the strategy. So when we talk about the strategy, it should include safer sex practices, regular HIV testing, counseling on risk reduction behaviors, counseling on adherence, and just adhering to their dosing schedule and taking that pill once a day. When we put adolescents in particular, because of the adherence, you may want to assess your adolescent patients a little bit sooner, maybe not see them every 3 months, maybe see them every 2, or maybe see them every month in the beginning to be sure that they're taking it, they understand the importance of taking it. It is proven to reduce HIV acquisition in unaffected individuals. This is part of the partner study and the Hackworth trial. I'm not going to go through the entire thing as we're getting shorter on time, but it is available on the internet. But there is a 90% risk reduction in those who had detectable drug levels of and 92% versus those who do not have detectable drug levels when you look at the 2 trials. So that's some really good information on how effective PrEP is. And this was Truvada for PrEP. The study looked at Truvada. It is safety and effective for those who are adolescents as long as they weigh about 35 kilograms. There was a study done specifically looking at adolescents. It was very effective for them as well. This is a breakdown of the study. The one thing to look at with adolescents, Truvada can cause a reduction in bone mineral density. And so you want to take that into consideration when you are placing a patient who may be an adolescent on Truvada if they are coming requesting it or they're at higher risk for HIV. DESCOVY came along a couple of years ago and was approved for PrEP. Again, you have to make sure that the patient is HIV negative, that you've screened them for hepatitis B. Again, greater than 35 kilograms. It can also be used in adolescents, just like Truvada. The difference is, let me back up just a little bit. The difference is in DESCOVY per PrEP is that DESCOVY per PrEP can be used in men who have sex with men and transgender women. It is not approved for anyone who was assigned female at birth or has a neovagina. Those patients who are transgender who have had quote unquote gender reassignment surgery. Currently, right now, there were no studies in that patient population. So if you're going to use DESCOVY, it is for a transgender female who has not had any reassignment surgery or gender affirming surgeries, and for men who have sex with men. So you would use Truvada in anyone who is assigned female at birth or has a neovagina. All of the top clinical aspects in the United States and global health guidelines have accepted PrEP. They all basically have about the same criteria for patients who should be placed on PrEP. If you look at the CDC, the WHO, ACOG, the International Antiviral Society, and the American College of Health Association, all of these organizations have clear criteria for the use of PrEP and decreasing the risk of HIV infection. They all include PrEP as a preventative option for HIV negative individuals, emphasizing the importance of counseling and adherence and risk reduction, and confirming that they're HIV negative prior to starting the PrEP, and that it is part of an ongoing risk assessment. So in summary, STIs have reached a critical high in the US, particularly among populations at risk for HIV. There is a relationship that exists between STIs and HIV risk, which are linked by biological, behavior, and epidemiological social determinant factors. Avoid missed opportunities. So regardless of the outcome of an STI test, whether it's positive or negative, you want to have a sexual health conversation with that patient, which is essential to assess their STI for future STI risk and the risk for HIV. Identify any of those patients who may be at risk for HIV in your practice, offer them PrEP, the appropriate PrEP to the appropriate patients as part of your comprehensive HIV prevention plan. And any questions, my contact information for my email for my office is here. So it's thackworth@absolutecare.com. Feel free to send me an email. Just put where you saw my presentation. I am giving this presentation at a couple of different conferences. So just let me know where you saw the presentation, and any questions or information that I'm able to share with you, I'll be happy to do so. So thank you again for letting me present the information to you today. And I hope that you was able to get some information that was new to you and found that to be useful. So thank you very much.